we're talking about the pitching phases. The first step of the pitching phase is the wind-up. The purpose of the wind-up is to set a rhythm that establishes a synchronized timing of the body parts. At the start, the two hands are together and near the body anywhere from the belt to the head as he takes a step back with the leg contralateral to the throwing arm. This contralateral leg is the stride leg, while the ipsilateral leg is the support leg. With the weight transfer, the body rotates 90 degrees as the stride leg flexes at the hip and knee so the pelvis can rotate towards the throwing shoulder and the lumbar spine flexes slightly. The body winds up so that all the segments of the body, from the legs to the arms, are able to contribute to the ball's propulsion. The next phase is called the cocking phase. Cocking is divided into early cocking and late cocking, according to the contact of the forward foot on the ground. Cocking begins when hands separate and ends when abduction and maximum lateral rotation of the shoulder is achieved. In early cocking, the scapula is retracted and the humerus is abducted, laterally rotated and horizontally extended. The elbow flexes. The stride leg begins to extend the knee. Abduct, medially rotate and extend the hip, and evert, plantar flex the ankle. The non-throwing shoulder is abducted and its elbow is extending. The body's center of gravity is lowered because the support knee and hip are flexing and the hips and pelvis begin to rotate forward. Late cocking begins when the stride foot hits the ground. At the time of foot contact, both arms are elevated about 90 degrees and in line with each other along the plane of the shoulders. When maximum shoulder lateral rotation and abduction to at least 90 degrees occur, the static stabilizers of the shoulder and the glenohumeral capsule and ligaments serve to limit further motion. At the end of late cocking, the lumbar spine hyperextends to add the shoulder's lateral rotation. The supraspinatus and infraspinatus are particularly active in late cocking. After the cocking phase comes the acceleration phase. Acceleration starts with maximum shoulder lateral rotation and abduction and ends when the ball leaves the fingers. The movement in this phase includes scapular protraction, humeral horizontal flexion, and medial rotation and elbow extension. Just prior to the ball release, the shoulder is still about 90 degrees of abduction. During this phase, the speed of the arm has increased significantly in a relatively brief period, beginning from almost 0 degrees per second at the end of cocking to 7,500 degrees per second by the end of acceleration, a time of 50 milliseconds. The last phase is called the follow-through. Follow-through occurs from the point of ball release to the completion of motion when the support leg moves forward and contacts the ground to stop forward body motion. It is divided into early and late follow-through, according to the point of maximal shoulder medial rotation. Early follow-through is completed rapidly in less than 0.1 seconds. Trunk rotation and scapular motions occur and are diminished to a varying extent from one style to another, depending on the individual thrower. The rotator cuff, especially the lateral rotators, must decelerate the arm after ball release and work against the momentum distraction forces occurring at the shoulder.
Next, we will be covering the muscles involved in each of the throwing phases. During the wind-up phase, the infraspinatus, teres minor, pectoralis major, and subscapularis are all involved in shoulder adduction. The sartorius, gracilis, semimembranosus, semitendinosus, biceps femoris, and gastrocnemius are all involved in knee flexion, and the rectus femoris, iliopsoas, pectineus, and the adductors longus and brevis are involved in hip flexion. Next is the early cocking stage. The pelvis achieves maximal rotational velocities of 400 to 700 degrees per second during this phase. The supraspinatus, infraspinatus, and teres minor externally rotate the shoulder and position of the humeral head on the glenoid. The serratus anterior and the scapular retractors position the glenoid in upward rotation and retraction, providing a stable base on which the humerus can rotate. The actions involved are hip abduction, hip extension, knee extension, shoulder abduction, shoulder lateral rotation, wrist extension, and finger and thumb flexion. The gluteus medius gluteus minimus, tensor fasciae latae, and the sartorius are all involved in hip abduction. Gluteus maximus, biceps femoris, semitendinosus, and semimembranosus are involved in hip extension. The rectus femoris, vastus intermedius, vastus lateralis, vastus medialis, and tensor fasciae latae are involved in knee extension. The supraspinatus and medial deltoid are involved in shoulder abduction. The teres minor, infraspinatus, and supraspinatus are involved in shoulder lateral rotation. The extensor carpi radialis longus, extensor carpi radialis brevis, and extensor carpi ulnaris are involved in wrist extension. And the flexor digitorum are involved in the finger and thumb flexion. Next is the late cocking phase. In this phase, the teres minor and the infraspinatus are active in delivering extreme amounts of external rotation. The rotator cuff muscles provide a compressive force of 550 to 770 newtons during this phase. The biceps muscle reaches peak activity as it flexes the elbow, limits anterior translation, and provides a compressive force on the humeral head. As the shoulder approaches maximum external rotation, the subscapularis, pectoralis major, and latissimus dorsi are eccentrically contracting, applying a stabilizing anterior force to the glenohumeral joint and halting external rotation. At termination of late cocking phase, the arm is positioned at 95 degrees of elbow flexion, 165 to 175 degrees of external rotation, 90 to 95 degrees of abduction, and 10 to 20 degrees of horizontal adduction. The next stage, acceleration, the trunk continues to rotate until initiating a transfer of potential energy through the upper extremities. The scapula protracts to maintain a stable base as the humerus undergoes horizontal adduction and violent internal rotation. This rapid motion delivers the arm from as much as 175 degrees of external rotation and 100 degrees of internal rotation. The subscapularis reaches maximum activity during this phase, along with the pectoralis major and the latissimus dorsi, producing the violent internal rotation of the humerus, reaching forces as high as 185% of its maximum muscle test strength. Internal rotation velocities as high as 7,000 to 9,000 degrees per second have been reported. The serratus anterior reaches maximum activity during the acceleration as it promotes scapular protraction, providing a stable glenoid for humeral rotation. During acceleration, the elbow initially flexes from 90 to 120 degrees, then rapidly extends to nearly 25 degrees. Maximum elbow extension angular velocity occurs just before the ball is released and may reach an angular velocity of over 2200 degrees per second. Non-dominant rectus abdominis and abdominal obliques show significant activity over their dominant side counterparts during acceleration to accentuate pelvic and trunk rotation and tilt. Concentric rectus femoris contractions contribute to lead leg hip flexion and knee flexion, providing a stable front side to help create increased angular momentum of the trunk. Forward trunk tilt reaches a mean of 32 degrees to 55 degrees and a maximal angular velocity of 300 to 450 degrees per second at ball release. Next, in the follow-through phase, the body continues to move forward with the arm until motion has ceased. Horizontal adduction increases to 60 degrees and muscle firing decreases. During the follow-through stage, the actions involved are hip extension, hip adduction, knee flexion, and knee extension. During the hip extension action, the biceps femoris, semitendinosus, semimembranosus, gluteus maximus, gluteus medius, and adductor magnus are all involved. For hip adduction, the adductor magnus, adductor longus, adductor brevis, and gluteus maximus. For knee flexion, the muscles involved are biceps femoris, semitendinosus, semimembranosus, sartorius, and gastrocnemius. And for knee extension, the muscles included are the rectus femoris, vastus lateralis, vastus medialis, and vastus intermedius.
There are many injuries that can occur while throwing a baseball. Some of these injuries can occur in the shoulder joint and the spine, but what I want to focus on is a common injury that occurs in the elbow. This injury is a tear in the ulnar collateral ligament, or UCL, or more commonly known as the Tommy John ligament. To discuss a UCL rupture, we must first understand what causes a UCL rupture and what leads to Tommy John surgery. It is a fact that a single pitch does not rupture ligaments and causes elbow injuries and Tommy John surgery. The UCL is torn microscopically over time in a flawed pitching delivery. Throwing so hard, so often, a pitcher causes constant strain and stress on his arm and ligaments. A UCL injury occurs during the acceleration phase because the overhead throw causes the greatest amount of valgus stress to the elbow. Extension occurs at a rate of up to 2,500 degrees per second and continues to 20 degrees of flexion. During this phase, the forearm lags behind the upper arm and generates a valgus stress, while the elbow is primarily dependent on the anterior band of the UCL for stability. During the acceleration phase, valgus stress can exceed 60 Newton meters, which is significantly higher than the measured strength of the UCL and cadavers. The valgus force can therefore overcome the tensile strength of the UCL and cause either chronic microscopic tears or acute rupture. In other words, as the forearm lays back in the external rotation and reaches maximum external rotation, valgus stress is pulling the bones in the elbow apart while the UCL stabilizes it. Over time, this can cause the UCL to tear and eventually rupture. Another interesting fact about the UCL is that during the acceleration phase, valgus stress can exceed 60 Newton meters, which is significantly higher than the measured strength of the UCL and cadavers. This means that the valgus stress that the pitcher experiences in their elbow often exceeds the measured strength of the UCL and cadavers. Theoretically, this means the pitcher should tear his elbow every time he throws due to the amount of torque being placed on the ligament. The idea that the surrounding muscles can support the UCL and prevent injury is nothing new, but one that is often ignored by pitching coaches around the world. Strength training has a positive benefit on injury prevention as well as performance. So how is it possible to pitch without suffering traumatic injury every time out there? In Biomechanics of the Elbow during baseball pitching, written by Warner, they conclude that the triceps, wrist flexor pronator, and the acromius activity during peak valgus stress suggest that these muscles may act as dynamic stabilizers to assist the ulnar collateral ligament in preventing valgus extension overload.